name is Stephen Brunton. I am a family physician and I practice in rural South Carolina. We have a lot of patients with diabetes, a lot of patients with kidney disease, and it's very challenging, but it's also very exciting. Actually, we're such a small town. Our closest restaurant is a truck stop. In fact, it's our only restaurant, so it is a joy to join you, at least virtually, in this situation. I'm going to be talking today about how the treatment for DKD, diabetic kidney disease, has changed dramatically. When I started managing diabetes, all we really had was insulin and leeches. We've come a long way, and we have a lot of therapies that really speak to the pathophysiology of diabetes, but also the pathophysiology of kidney disease. And so we'll be addressing that throughout this presentation. Now, this program is sponsored and supported by the Primary Care Education Consortium, and we have an educational grant from Bayer Healthcare Pharmaceuticals. Now, this program is also developed in collaboration with the Primary Care Metabolic Group. Now, this is a national group of clinicians with interest in metabolic disease, and it's free to join, so it doesn't get better than free. And that offers both free CME, but also discounts on conferences and a lot of resources that can help you in the management of metabolic disorders. And actually, this presentation will also live on that site, so if you want to come visit again, you have that opportunity. Now, with regards to continuing education credit, this program has been reviewed and has been given at least 1 hour of CE credit, CME credit from the American Academy of Family Physicians. And this credit can be used by other clinicians as well. And we'll talk in a moment about how you might be able to get additional credit. So the American Association of Nurse Practitioners Certification Program and the American Nurses Credentialing Center also accept AAFP prescribed Category 1 credit, so you can get an hour of credit there. And similarly, physician assistants can also get that credit as well. Now, the additional credit I was talking about is called Translation to Practice, and you get additional 2 credits if you make a commitment to change practice behaviors in your post-presentation survey. And in that survey, you're going to be asked to commit to changes in your practice behaviors, specify what those changes are, and then give us your name and email address. And if you don't do that, unfortunately, you won't be eligible. But if you do, approximately 6 weeks later, we'll be contacting you and asking if those changes were made, along with a few additional questions. And if you complete those changes, you get an additional 2 hours of credit. So it's a great deal, and frankly, really is fairly easy to do, but gives us a chance to really evaluate whether this has been impactful for you. Now, as with all continuing education programs, you want to make sure that there's been good balance, and this program has been evaluated for independence, objectivity, and rigor, and any potential conflicts of interest have been mitigated. These are my conflicts of interest. These I serve on various advisory boards and speakers bureaus, and they're listed here. Other folks involved, Austin Ulrich, who is a medical writer, and Michael Hannick, who's a CME reviewer, they have no disclosures to report. All right, so what do we want you to accomplish? Well, there's several things that we want to specifically for you to be able to do after this program. One is to identify patients at risk for chronic kidney disease who should be screened for albuminuria using the UACR, urine albumin creatinine ratio, and reduced EGFR, that's estimated glomerular filtration rate, to lessen diagnostic delays. And unfortunately, there's a lot of diagnostic delays, and we'll talk about that. We also want to incorporate newer agents such as the SGLT2 inhibitors and middle-corticoid receptor antagonists into treatment plans for eligible patients with CKD and type 2 diabetes. And lastly, review new and emerging data regarding the use of MRAs in patients with CKD and DKD. All right, so let's start. How do we define these conditions? Well, the KDIGO, the KDIGO stands for Kidney Disease Improving Global Outcomes, which is what we all want to do. Anyway, their definition of CKD, it's an abnormality of kidney structural function that present for a minimum of 3 months with implications for health. And their criteria, as you can see on the right, are if there's markers of kidney damage, one or more of these, either albuminuria, urine sediment abnormalities, persistent hematuria, electrolyte and other abnormalities due to tubular disorders, abnormalities detected by histology, structural abnormalities detected by imaging, or a history of kidney transplantation. So those are the markers of kidney damage. Now, if we look to the left here, that also includes a decreased glomerular filtration rate of less than 60. Now, DKD is really the presence of CKD in patients with type 1 or type 2 diabetes, regardless of the background. So it's fairly listed here as to the way we can identify these patients. And once again, patients with diabetes are more prone to getting kidney disease. The most common causes of kidney disease in the United States are diabetes, number 1, and hypertension, number 2. So in terms of how frequently these are, more than 1 in 7 adults in the United States have CKD, and that's about 35.5 million people. However, if you have diabetes, your risk is much greater. About 30% of patients with diabetes have chronic kidney disease. And while it's very common for us in primary care, it remains, unfortunately, very underdiagnosed. And particularly when we see patients in early stages, they often are asymptomatic. So we really need to be doing the screening. And unfortunately, if we won't do that screening, we're going to overlook those patients. Now, if in terms of looking at frequency, you see there's a difference as you get older, particularly we talk about 65 plus being older. My definition of geriatrics is anybody 20 years older than I am, but still, if you see that the risk of CKD is so 3 times that of people in the middle age group, and certainly much more frequent than the youthful folks. However, if we look also at that women have slightly increased prevalence of CKD, and particularly in non-Hispanic black population, it is significantly increased. So you can see here there's a differential. The reasons for that, certainly, as we understand, you get older, your kidneys, there is declined kidney function. But certainly, certain ethnicities are at greater risk, partly potentially because of a decrease prevalence of hypertension, but also genetic predisposition as well. Unfortunately, the mortality is significantly increased when you have CKD. And if you look at this graphic, it really dramatically shows you that. The dotted line reflects a mortality in people without diabetes or kidney disease. And that's the baseline. And you see that if you have no kidney disease but diabetes, then it's basically your risk is 4% higher. However, if you have albuminuria and impaired GFR, the risk is 10 times that mortality of a person with diabetes without kidney disease. So the risk is huge, and that really is imperative upon us to try and diagnose these patients early and intervene earlier as well. All right, so what are the consequences? Well, as I mentioned, as you saw from the previous graphic, kidney disease is a leading cause of mortality in the United States, and it can lead to kidney failure and it might require dialysis or at least kidney transplantation. And we'll talk in a moment about how we might identify these patients earlier and try and prevent that occurring. But the kidney and the heart are very closely related. If you have kidney disease, you're much more likely to have cardiovascular disease. And chronic kidney disease is associated with other multiple additional complications, certainly hypertension, which will aggravate the potential for worsening kidney disease, but also volume overload, electrolyte abnormalities, metabolic acidosis, anemia, and metabolic bone disease. All of these can be seen, and by treating kidney disease earlier, we can help prevent some of these abnormalities. So what is the role that we have as primary care clinicians? Well, Certainly, we see these patients earlier, so we can facilitate early screening and diagnosis, which is, once again, a critical thing to do. Also, if we can implement these interventions early, then we can help prevent not only the decline in kidney disease, but also prevent some of the cardiovascular morbidity and mortality. We have the opportunity to use lifestyle interventions, which we should be expert at, but also optimize risk factor management and then use therapies that have evidence of cardiovascular and kidney benefits, such as SGLT2 inhibitors, the non-steroidal mineralocorticoid receptor antagonists, which I'll talk about in more depth later, and the GLP-1 receptor agonists. All of these therapies can make a big difference with regards to how we manage kidney disease. And then if the disease is progressing or we have concerns about its management, then the use of our nephrology colleagues can make a big difference. We'll talk about when and how referral might be appropriate. All right, so let's talk about some of the newer therapies. Once again, there's been I think a shocking thing that we have all these therapies now, and I said things have changed a lot since I've been starting to manage these patients. And there's a study done looking at a cross-sectional analysis of over 1 million patients from the Veterans Administration database. And of the patients with type 2 diabetes and chronic kidney disease, only 12% were prescribed an SGLT2 inhibitor. And I'll show you that this really make a big difference in their therapy. But only 10% were prescribed a GLP-1 receptor agonist. Now, as shocking as that is, the people that had the most severe kidney disease and higher cardiovascular kidney risk were less likely to be prescribed either of these agents. And there's maybe a number of reasons for that. And I think we see good evidence-based interventions make a difference in these patients. We'll talk about that as well. So you remember the question from your pre-survey, which of the following is true about implementing newer agents for treating type 2 diabetes and CKD based on real-world study of approximately 1.2 million patients? Well, once again, only 12% were prescribed an SGLT2 inhibitor. That's startling. All right, so let's talk about identification, screening, and diagnosis of patients with CKD. Now, as I mentioned, it's important for us to really make this diagnosis early because early detection treatment is critical because it prevents the disease from progressing, improves adverse outcomes, including end-stage kidney disease, that's ESKD, cardiovascular disease, and death. And since it's often asymptomatic, particularly early on, the lab is an important strategy for us to use to detect these patients early, and by doing that, we can successfully implement these changes in a primary care setting. So what are the risk factors? Well, it's a number of things, and a lot of these sort of obviously are obvious. Certainly, getting good glycemic control has always been the basis of trying to minimize some bad outcomes in diabetes. But if you have a family history of CKD, obviously, if you haven't chosen your parents well, that puts you at increased risk. Hyperlipidemia, uncontrolled hypertension and obesity, and of course smoking, which is, patients should not be smoking for any reason, and this just aggravates the risk factors for CKD and cardiovascular mortality as well. Now, this is the heat map that was developed by the KDIGO group, Kidney Disease Improving Global Outcomes group, and it tries to stratify the risk of patients based upon the grade of glomerular filtration rate as well as the albuminuria categories. And just as you would expect in a street light, green meaning go, red meaning stop, that really gives you a sense of the concern. Not that when we need to stop and reflect what we need to do with these patients. So if we look here on the left-hand side, the classification of CKD, grade 1 is normal or high EGFR of 90 or more. When we talk about grade 2, often we don't diagnose that because, well, frankly, in our clinic, we don't even get EGFRs unless they're under 60. Now, unfortunately, when that happens, they're already at least a grade 3, if not worse, level of impairment. Now, grade 3 is divided into two groups, 3A and 3B. It's the most common and also really reflects increased risk, if you will. So grade 3A is a mildly to moderately decreased EGFR 45 to 59. 3B is 30 to 44. Once you get beyond 3B, this is when we're really concerned. We're severely decreased. 15 to 29 severely decreased, and kidney failure is less than 15. Now, if we look to the right-hand side, you see here the gradation of albuminuria is less than 30, 30 to 299, and greater than 300. So even if you have a normal GFR and you have severe albuminuria, these patients need to be treated much more aggressively and potentially referred to the your nephrology colleague. Now, the numbers in these blocks reflects how frequently these patients need to be seen. And so if you have, for instance, a 3A grade of a GFR, but you have a severe albuminuria, these patients need to be seen at least 3 times a year, but potentially referred as well, because these patients are going to progress and already have significant renal impairment. So this graph is something very useful. It's going to be available in your resource toolkit, and this is something, frankly, we put on the wall for our patients to see, so they can see where they sit in this whole graphic. And it's very instructive and actually very, very helpful. All right, so when should we be screening patients with diabetes? Well, the recommendations are that, by the American Diabetes Association especially, is that you start screening patients with type 1 diabetes after 5 years of diagnosis. And that's because these patients present pretty dramatically early, usually in crisis, and so we make that diagnosis, and we'll be able, and kidney disease doesn't really occur until after a few years. In patients with type 2 diabetes, however, they often have that disordered pathophysiology for even 10 or 15 years before the diagnosis is made. So there's already likely to be some decrease in kidney function. So the recommendation is that you start screening these patients at diagnosis and then follow them up on a regular basis, depending upon the heat map as well. And how do you screen them? It's not just the EGFR. Basically, we need to be doing a spot urine albumin-creatinine ratio. Now, back in the day, we used to think we had to do a 24-hour urine creatinine clearance, and we'd have patients taking around these big jugs and collecting their urine for 24 hours. We don't have to do that anymore. Patients didn't like it. Often they weren't complying with doing it. So now we can use a spot urine albumin-creatinine ratio, and that makes life a lot easier. All right. Unfortunately, testing for CKD has not been very good. About 80% of patients who are high risk have not been tested, and you can look at the sort of map of the USA here and decide where you sit and how poorly testing is done. Now, there's ranges there, and certainly even in my state, in South Carolina, it's only about 14 to 15% of patients that are actually being screened. So there's a lot to be done and a lot of catch-up, and that's part of the focus for this program. Well, there was a study that was done about why this is important. It's called the REVEAL study, and they looked at the decline in EGFR before and after the CKD diagnosis. And the mean annual decline in EGFR decreased significantly following the CKD diagnosis. You can see that annually there's a decrease in 3.2 mil per minute, and as you watch now, once the diagnosis is made, it's decreased to 0.74 mil. So this is a dramatic decrease just by making the diagnosis and then giving you the opportunity to implement some changes. All right, so let's talk about the pathophysiology. There's several factors involved in the deterioration of kidney function in patients with diabetes. And you see here that the metabolic factors, hemodynamic factors, inflammatory factors, fibrotic factors, and genetic and epigenetic factors. All of these can contribute to this. And the pathways involve both angiotensin and mineralocorticoid receptors. Now, this provides us understanding of what might be occurring within the kidney, but also gives us some understanding as to how we might actually try and prevent that progression. So the pathophysiology provides us some opportunities to intervene and prevent the degradation that occurs. So what actually defines the diagnosis of CKD? Well, it's a persistent urine ACR of 30 milligram per gram or more, and or the persistent EGFR of less than 60, and some of those other evidence of kidney damage I referred to at the beginning of the program. Now, if the result is positive, you want to confirm it, so you need to repeat it because it may just be temporary or some spurious causes. And if you're unsure and you want a more precise estimate of glomerular filtration rate, you can use the cystatin C and creatinine. But it's only these persistent MRAs that we utilize to define CKD. So if we find a potential diagnosed CKD and you repeat it, then this patient has CKD and they need to have these treatments, and we want to use evidence-based treatments. So when do we think about referral? Well, the ADA gives us certain categories. Certainly if you're unsure of the etiology, there are other rarer causes besides diabetes or hypertension. So if you're unsure and you need to intervene specifically, that gives you a chance to potentially nephritis or some other issues. If the patient has difficult management issues, and that's noted below, whether they have anemia or secondary hyperparathyroidism, or there's a significant increase in the albuminuria despite good blood pressure management, if they have metabolic bone disease or resistant hypertension or disturbances in electrolytes, or they're in that graph we talk about, the heat map, those give us suggestions as to when you might want to refer. Particularly though, if the EGFR is less than 30, that is, they're basically stage 4 kidney disease, these patients need to be evaluated for potential kidney replacement, disease management, and also if there's disease is rapidly progressing, much faster than you expect, then you want to intervene to prevent a more rapid decline. So now we've gone through that. What can we do to help manage these patients? What does the evidence show us? Well, the American Diabetes Association and the KDIGO group came up with a consensus statement, and that recommends that all patients with either type 1 or type 2 and chronic kidney disease need to be treated with a comprehensive plan that's agreed upon by us and the patients. And the goal is to optimize nutrition, exercise, smoking cessation, and weight. We talked about that, the lifestyle management. And then we layer these other evidence-based pharmacologic therapies to try and preserve organ function, and then use other therapies to attain at least good targets for glucose, blood pressure, and lipids. So it's a comprehensive plan. And this can be very challenging for patients, but that's why we really need to have an agreement and a buy-in by the patient in terms of how we get this done. All right. Now, the American Diabetes Association standards of care recommend the optimizing of glucose control to reduce the risk or slow the progression of chronic kidney disease. And that's obviously what I want to do. And it's always been the basis of why we look at glycemic control. But importantly, it's not just that. It's blood pressure as well, because that's good. The two is a deadly combination. We want to reduce blood pressure variability, and that hopefully will not only reduce the risk, but also slow the progression of chronic kidney disease. Well, what are our glycemic targets? Well, it depends. It's not just the same for everybody. We want to personalize it for the patient. So we individualize it, but we do want to get control from 6.5% to 8% for patients with chronic kidney disease and diabetes who aren't on dialysis. Now, the Certainly we want to use more stringent goals in early kidney disease, grade 1. But less stringent goals, and we talk about less than 8, if the person has severe kidney disease, that is, once again, that's when they have an eGFR of less than 15, or there's macrovascular complications, or they have a lot of comorbidities, a short life expectancy, impaired hypoglycemia awareness, or if they don't have resources to manage the hypoglycemia, or they're at high risk. And a lot of this is because of the hypoglycemic risk in these people, because the ACCORD study showed us that even though you get great control, mortality isn't improved if you're having hypoglycemia. So that may be the biggest risk, particularly in these patients where we identify them as having less stringent goals. So what are the targets? Well, the ADA says, once again, we want to get an A1C of less than 7 for most of these patients. However, as I said, if the A1C, if the person has a risk of severe hypoglycemia, an A1C less than 8 is a better target, as well as, once again, listed here then is advanced microvascular or macrovascular complications, because you don't want these patients getting hypoglycemia and putting them at risk for CVAs or MIs. And also if they have long-standing diabetes in which the goal has been difficult to achieve, despite all the self-management education and glucose monitoring or effective doses, then perhaps we can be a little bit less stringent with our A1C goal. Now, KDIGO kind of agrees with that, but in terms of, they also talk about blood pressure target of less than 120 to slow the progression of CKD, and they recommend, as most of us do, if the patient has hypertension, then the use of an ACE inhibitor or an angiotensin receptor blocker, but titrated to the maximum tolerated dose. Sometimes we don't, we get more benefit by using a higher dose. Now, the ADA standards of care basically talk similarly, but they also talk about optimizing glucose control and also optimizing blood pressure and decreasing decreasing blood pressure variability. Now, what about lipids? Well, certainly that's a very important aspect as well, particularly in patients that have atherosclerotic vascular disease. So high-intensity statins need to be used for a secondary prevention benefit, and also for patients at high risk for atherosclerotic vascular disease, if they're 40 to 75, using that for prime prevention. You can use a moderate intensity statin for patients that aren't at high cardiovascular risk, but still, the importance of statins need to be in the water supply. Let's all agree to that. But certainly, they have an important role here. Now, the KDIGO has come up with recommendations, as does the ADA, in terms of how we improve outcomes in patients with diabetes and CKD. Now, I know this is an eye chart. I'm going to go into this, break it down. But this really is the algorithm recommended for the management of these patients with diabetes and CKD. So let's look at the first line. The first line basically says, we want to look at lifestyle. We always want to look at lifestyle, but healthy diet, and you can see all the healthy components there, physical activity, stopping smoking, and weight management. That's the basically foundational therapy for patients with diabetes and CKD. And you see on the left-hand side, it says regular risk factor reassessment every 3 to 6 months. It's just asking patients. Patients hate losing weight and then you don't either look at it or acknowledge it. So, but certainly reinforcing that. And then we look at first-line drug therapy. Now, SGLT2 inhibitors have really revolutionized the way we treat CKD, because the evidence is there. I'll talk about that in a moment. But the suggestion is that you initiate if the eGFR is 20 or more. It used to be different than that, but the studies have shown that we actually get a benefit, even independent of the glucose role, but actually there's a kidney preservation role with the SGLT2 inhibitors. So you continue until dialysis or transplant. Metformin can be used as well, and should be, if the eGFR is over 30. We used to be very frightened about metformin, thinking we were going to cause a lactic acidosis. And we've seen in the states that, frankly, certainly if the eGFR is less than 45, you might use a lower dose, half dose perhaps, but you can still use it. RAS inhibition also is a dramatic change in our management of patients with diabetes and potential of CKD. And that was shown over 20 years ago with earlier studies, 30 years ago, that the use of RAS inhibition can change the trajectory of chronic kidney disease. And also, as we talked about, the use of moderate high-intensity statin. Now, the ADA and KDIGO, they have a consensus statement. They talk about first-line glucose-lowering therapy, once again, recommending an SGLT2 inhibitor with proven kidney or cardiovascular benefit. And that's important because some of the studies, and I'll show you which ones, have not shown a benefit, but most of them have. And the use is for patients with type 2 diabetes, CKD, and EGFR of 20 or more. And you can continue using them, once again, continue using them until initiation of dialysis and transplant. I mentioned metformin as well. Dose could be reduced to half a dose in patients with EGFR of 30 to 44, and some patients who might be at risk of lactic acidosis if it's 45 to 59. So here are the various SGLT2 inhibitors that are available, and the recommendations are when to use it depending on the dose. And this is just based upon the studies. Once again, initially, a lot of them thought, well, you don't want to use them if the EGFR is under 45. Well, that's been shown in other studies that you can. But the dose adjustments and various medications you want to use when and how is listed here. However, ertugliflozin, while it's in the SGLT2 class, hasn't shown benefits in terms of reduction of renal risk, cardiovascular risk. So they may be very good at lowering glucose, but they aren't recommended to use in terms of prevention of CKD. So once again, we have these first-line therapies in terms of other therapies. And once again, the ACE inhibitor or angiotensin receptor blocker recommended for patients with either type 1 or type 2 diabetes who have hypertension and albuminuria, and you titrate it to the maximum antihypertensive or highest tolerated dose. Similarly, a statin for all patients with type 1 or type 2 diabetes and CKD. In terms of the prime prevention, you use a moderate intensity drug or high intensity for patients that either have atherosclerotic vascular disease and some patients with significant atherosclerotic vascular disease risk factors. Okay, so here's the second line now of that algorithm. We've got the patient on SGLT2 inhibitor or metformin, and then you reassess once again the glycemia, albuminuria, blood pressure, risk factors, and lipids. And if you need to use additional therapy, then a GLP-1 receptor agonist may be used to get to that glycemic goal. And if you need additional drugs to use it, then you can layer them on top to get to your glycemic target. Once again, we have a lot more therapies now than we used to have in the past. Now, with regards to the GLP-1 receptor agonists, the recommendation, and I'll show you a study now that suggests they may have a specific benefit in patients with chronic kidney disease, but a GLP-1 receptor agonist with proven cardiovascular benefit recommended for patients with type 2 diabetes and CKD who do not meet their individualized glycemic target with metformin and or an SGLT2 inhibitor, or they're unable to use these drugs. So the combination can be very good, and particularly it may be just those in patients who can't tolerate an SGLT2 inhibitor. So we have some flexibility there, and we have the use potentially of multiple drugs. Now here the GLP-1 receptor agonists, the dosing that they can be used in patients with chronic kidney disease. Now it's exenatide says one needs to be very cautious that one uses this in stage 3B chronic kidney disease, and not to use the once weekly formulations. And patients that have worsening kidney disease, it's not recommended they use it. But you look at most of them don't need to be adjusted in terms of when you do see CKD, even up to stage 5. That doesn't apply to lixisenatide, but the others, because they basically are safe to use with CKD. All right, so let's talk a little bit about an additional therapy, and that's the non-steroidal mineralocorticoid receptor antagonists, non-steroidal MRAs. And frankly, the benefit for that can be in terms of ACR if it's 30 or more and the patient has normal potassium. And the reason for that is, and I'll show you the studies that show that can be very beneficial. Now, if you really aren't getting the hypertension controlled, you can use a dihydropyridine calcium channel blocker and a diuretic if necessary. And if that is not enough, you can use a steroidal MRA. But these are for patients typically that don't have, that for all patients, but specifically for patients with type 2 diabetes, the non-steroidal is recommended. And I'll show you why, because the studies have been done in that population and shown to have beneficial outcomes. So the ADA KDIGO consensus statement now recommends that these non-steroidal MRAs are used if they have a proven kidney and cardiovascular benefit for patients with type 2 diabetes, an eGFR of 25 or more, normal serum potassium, and albuminuria of 30 milligram per gram or more, despite maximum tolerated dose of the renin-angiotensin system inhibitor. Now, you can use them together. It's not one or the other. If one is trying to get adequate control, you can use them both. So what are the pillars that are recommended of DKD management? Well, the foundational thing is lifestyle intervention. Everybody should get that. But then looking at these different pillars, the ACE inhibitor, or ARB, maximum tolerated dose, as I mentioned, the SGLT2 inhibitor with primary evidence of reducing CKD progression. As I mentioned, the non-steroidal MRA, and Finerenone is the only agent currently available in that category. And there's now a fourth pillar, and that's the recommendation of a dual-purine receptor agonist. And that's based upon recent data from what's called the FLOW trial. And the FLOW trial is demonstrated that there's a reduction in kidney disease progression with semaglutide in patients that had type 2 diabetes and CKD. Now, that's been presented at scientific meetings. The definitive publication is going to be coming out, but at least preliminarily, we see that it has an impact in terms of improving chronic kidney disease. All right, so that was a question in your pre-survey, if you remember, and you'll note here that diuretics are not one of the four pillars. So the correct answer was not diuretics. All right, so what is an MRA? I say, that's the way I pronounce it. I'm from Australia. I pronounce A like I. Anyway, an MRA they've been around for decades, and they've been used, the regular MRAs have been used for a diversity of various disease states, heart failure, refractory hypertension, some of the nephropathies, and diabetic nephropathy has been a role, but they have not been typically used in that way, and I think largely because of concern about some of the side effects. But the benefit is that by inhibiting aldosterone at the mineralocorticoid receptor, you can prevent the activation of the mineralocorticoid receptor, and therefore you're going to get less remodeling. You get decreased inflammation, decreased fibrosis, and improved proteinuria. So you get the pathophysiological changes you want with this agent. Now, there have been a number of meta-analyses recommending and evaluating the benefit of mineralocorticoid receptor antagonists in kidney disease. And this is either an intervention either with this alone or when added to an ACE inhibitor, an ARB. And they compared it to a placebo or an active treatment. And you see here that the benefit, significant benefit, was reduced UACR by 22% and reduced proteinuria by 52%. Now, if you reduce proteinuria by 30%, that's considered to be very significant. Here we have it by 52%. Reducing systolic blood pressure by 2.5 millimeters of mercury and diastolic by 1.9, and reduced eGFR by 2.82 compared to placebo. So it does all the things you want to do. Now, unfortunately, it also increases the risk of hyperkalemia by 0.2 milliequivalents per liter. So that's one of the concerns about the general mineralocorticoid receptor antagonist. And that's where the role of the non-steroidal mineralocorticoid receptor antagonist fits in. So if we want to compare them, we see here that spironolactone and eplerenone are the regular middle cortical receptor antagonists, and they have indications that reflect, basically hypertension, particularly both of them. And you can see here that spironolactone has more indications, particularly for primary hyperaldosteronism, but also edema and heart failure. Finerenone is both highly potent as well as highly selective, and it's a balance in both the heart and the kidney, and it's been approved to improve kidney and cardiovascular outcomes in patients with type 2 diabetes and CKD, based upon a couple of studies called the Fidelio and Figaro studies, and I'll show you those in a moment. This drug was approved in 2021, and the beauty of it is that you get less steroidal side effects. That is, you get less gynecomastia, but also less hyperkalemia when you compare it to spironolactone or eplerenone. And I mentioned the indication is to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure in adult patients with chronic kidney disease associated with type 2 diabetes. So it's quite a broad indication. I'll show you the studies upon which that was based. There were basically several two phase 3 studies, the Fidelio DKD and Figaro DKD. Now these were randomized, double-blind, placebo-controlled, multi-center trials, and they were event-driven, and they were designed the same way. But they had different outcomes they were evaluating. The Fidelio study had over 5,000 patients treated with an ACE inhibitor or ARB, and they basically, the UACR was 30 to 300, EGFR 25 to 60, and their diabetic retinopathy or UACR greater than 300. So these were designed, once again, same baseline characteristics in terms of demographics of this population. And they were randomized to either Finerenone 10 milligram or 20 milligram or placebo. And this titration was based upon the potassium level as well as the change in EGFR. And that is how we basically dose them now, and I'll show you that in a moment. Now, on the Fidelio trial, once again, that's the DKD, is looking at the kidney outcomes. That was a primary endpoint of composite of time to first occurrence of kidney failure, sustained decrease of EGFR of over 40% or more, over 4 weeks or more, or kidney-related death. So that's the kidney study. The Figaro study, same design, but looking at a composite of time to first occurrence of cardiovascular death, non-fatal MI, non-fatal stroke, or heart failure hospitalization. Both were longer studies, and the Figaro study was published in 2021, the Fidelio study in 2020. So what did the study show? Well, in the Fidelio DKD study, you see there's a highly significant benefit in terms of the primary composite with an 18% decrease in this, but the p-value of 0.001. But also in terms of the secondary endpoint, there's a 14% improvement. And also even in terms of new onset of atrial fibrillation and flutter, also a decrease of 29%. Now, in the Figaro study, and this is also looking at the similar endpoints, they saw here that the primary composite was decreased by 13%, hospitalization, heart failure, and the secondary composite also decreased by 13%. So all of these were beneficial, particularly the new onset of heart failure was decreased by 32%. So how do we use these drugs? Well, firstly, the recommended starting dose is if the EGFR is 60 or more, you can use 20 milligrams a day, but don't initiate if the potassium is above 5, because even though it's less likely to cause hyperkalemia, you don't want to increase it in that situation. So the recommended dose is, if the serum potassium is less than 4.8, then you can basically start at 10 milligram once a day, and if it's over 4.8, once again, if it's under 4.8, you can use 20 milligrams, but over 4.8 or 4.8 to 5.5, you can maintain the dose of 10 milligrams once you've evaluated again. And if it's above 5.5, just hold it. So we have an opportunity, and basically the dosing is based upon the serum potassium. Once again, while you're less likely to get hyperkalemia with Finerenone, you still want to be cautious to make sure you don't get that way. The common side effects is still hyperkalemia, low implication for that, but still possible. Hypertension, hyponatremia. Now, it is also a cytochrome P453A4 inhibitor. So if they're using one of those drugs, you'd be very cautious, it's contraindicated, and then monitor serum potassium during the initiation or dose adjustment of either of those. And once again, the contraindication is the patients they're using a strong CYP3A4 inhibitor or patients with adrenal insufficiency. Now, a lot of the confusion occurred when people thought you couldn't use them together. You can. In fact, the use of them together shows even greater benefit. In this study, they looked at patients and their outcomes looking at a doubling of serum creatinine, end-stage kidney disease, or death due to kidney failure. And they had patients basically that were using in combination or conventional therapy. And the combination showed a hazard ratio of 0.5. That is, 50% of the patients did better in this primary outcome. 41% of patients did better with end-stage kidney disease, and all-cause mortality was decreased by 25%. So it's a very good combination. And they found that actually the estimated event-free survival from the composite kidney outcome, incremental gain was 6.7 years using this combination. So that's a great argument as to why you might want to use them both. Now, what are some of the barriers that we might have in primary care to utilize optimal therapy? Well, certainly there's clinical inertia. That's always a problem. We've got a lot of things we're trying to manage in primary care, and that can be a problem. The other may be that there's just not an awareness of chronic kidney disease, either among patients or even amongst ourselves. And in the past, we haven't really wanted to bring up kidney disease as a diagnosis of patients because there wasn't much we could do about it. We're in a different era now. There are things we can do. So some of the, once again, maybe we're not aware of some of those things, and it may not be the priority it needs to be. And hopefully we've reinforced why this is important and the linkage between kidney disease and heart disease. And heart disease is the most common cause of mortality in these patients. This should be a call to action for us. And these patients may be fairly complicated. Once again, we're busy. We may not have the time and resources. And we need to have really good collaboration with our specialists. And often there hasn't been clear parameters. And now hopefully KDIGO has given us a real guideline so we want to use it. So hopefully overcoming these barriers is going to get patients to get earlier treatment and improve their outcomes. So what do we want to accomplish in this program? Well, frankly, I hope that we've talked about and given some real guidelines in when we might identify these patients who are at risk for CKD, who should be screened for albuminuria using the UACR and reduce EGFR to lessen some diagnostic delays. Also incorporate some new agents such as the SGLT2 inhibitors and MRAs into treatment plans for eligible patients with CKD and type 2 diabetes, and potentially also GLP-1 receptor agonists in their appropriate role. And look at new and emerging data regarding the use of MRAs in patients with CKD and DKD. Now, there's a resource toolkit I mentioned early on. This resource toolkit actually is a very useful toolkit for you. Not only are you going to have a video of this presentation, which you may or may not want to see again, but we also have other resources. It's going to have the references that we basically reflected on in the basis of this presentation, but also access to the updated ADA standards of care, which has a wealth of different information. You'll be able to get access to the KDIGO guidelines, also the heat map, and things that it's really worthwhile you're linking here, because you'll find this that will help you manage your patients with diabetes and diabetes kidney disease, hopefully much better. There's a lot that we have to do as clinicians to do this, and hopefully this toolkit will make life a little bit easier for you. Now, in terms of summary, let me just before I summarize what we discussed, talk about how significant impact that you can have on this. My daughter was diagnosed with diabetes at the age of 8, and she now, as a teenager, and has already kidney impairment. She's on an ACE inhibitor. She's being managed very appropriately. However, as a teenager, which, as you all know, is a disease in itself, teenagers are very hard to get under good glycemic control. So she's had a progression of her kidney disease in that process. And, as a parent, it's hard to make a difference. Certainly I talk with her clinician about how we might do that. And she's now on an ACE inhibitor and really she's getting older, taking her diabetes more seriously. But I see a lot of patients, type 2s in particular, who've had diabetes for a long time, who've never been told that they have kidney disease, and are actually shocked when they get that. And by utilizing these therapies, have been able to make a difference. So this is in all our purview. As I mentioned, unfortunately, only 12% of patients who are candidates for some of these therapies are getting it. SGLT2 is only 12%, whereas we see the data has made a big difference. So we as clinicians can change the trajectory of diabetes and diabetes kidney disease very dramatically, and once again the cardiovascular outcomes as well. So what I've tried to impress with you in the summary is that these diseases, CKD in type 2 diabetes, has increased risk for these cardiovascular events, as well as progression of kidney disease and mortality. And we're seeing, once again, worsening kidney outcomes over the last few decades. So screening for these patients on an annual basis at least, and including not just the EGFR, which doesn't give you the full story. We need to do the urine albumin creatinine ratio as well. Managing risk factors, once again, lifestyle, but also getting glycemic control, optimizing that as well as blood pressure, and that can hopefully prevent or slow the progression of kidney disease. And then we have now therapies, the use of RAS inhibitors. These really are unfortunately still underutilized. The SGLT2 inhibitors and Finerenone. These, frankly, provide organ protection and really change some of the pathophysiology of what's going on in the kidney. And for patients, selected appropriate patients with type 2 diabetes and CKD, this can be life-changing. Now, to get your certificate, once again, we've got the QR code. If you go there, there'll be a small evaluation, and then you'll be able to get your CE certificate. I thank you for your attention. I hope this has been useful to you. We have a lot of patients out there with kidney disease or at risk for kidney disease, and hopefully we can make a real difference in their prognosis.